All right, guys. So what I wanted to do this morning with you, as we are preparing you for the clinic, let me just say that my name is Dr. Michael Wong. I am a professor here in Southern California, so not too far away from you guys, and am excited to be working with you today. As we prepare, we spent some time preparing a series of things, interactive things for you to do, and what I'm going to do is create a little review of the big picture of how we envision rehab, musculoskeletal rehab, right? Outpatient rehab, the concepts behind it, so that when you play through the apps, you'll be able to see how all the different pieces are linked together because you guys are a fundamental piece of how we function to get the patients better. But I think it's so valuable that you're able to see and hear how we are thinking from a clinical practice guideline perspective on the examination and management. So I'm not going to talk a ton about the examination, but I think it's very valuable for you to hear why is it that we examine things the way we do. And I hope some of this is review, and I hope some of this is just helping you to pull things together. So you can see my screen, Catherine?
Yes, we can. Thank you.
Okay, perfect. So the only thing I'm going to say about ICF language is all the clinical practice guidelines that the Journal of Orthopaedics and Sports Physical Therapy puts out are all tied to the ICF language. That language is so important today for you to understand because it will make sense of all the crazy little things that we end up doing on our eval, asking you to treat. All of that is tied to the rehab theories behind the ICF label. And the reason why I think this is useful is because you can reuse this language from joint to joint. So I'm going to show you what I mean by that, okay? So I'm going to move forward. You can see the ICF has kind of broken itself into different pieces of which they're all interlinked. They talk about how impairments of body structure and function, like loss of range of motion, loss of strength, can then end up creating activity limitations, your functional limitations. I can't reach overhead to put on my shirt. That's a problem for me. And that problem, that functional limitation, becomes a participation restriction. It's a disability. I cannot go to work because I cannot put on my shirt. So I cannot function as a mailman or as a secretary or a worker in the car, as a car mechanic. So here you see all of these clinical practice guidelines. So the apps that we're playing with today cover all the clinical practice guidelines and more. And you can see in these clinical practice guidelines, there's all these recommendations for interventions, for examination. You will see how the app simplifies this and makes it really come to life. Okay, so overall, let me just move on to here. Think of this language as kind of like the 50,000 foot label that we use to apply to a lot of different common conditions you're going to see in the clinic. So I'm going to go over each one with you and we're going to discuss it together because I think there's a lot in your mind that you already know. We're just going to connect those dots together. The overall guidelines, all the clinical practice guidelines are going to call things by mobility deficits. So for example, adhesive capsulitis is known as shoulder pain and mobility deficits. Its primary impairment is someone is stuck. Someone cannot move their shoulder enough. Here is movement coordination impairments. I will talk about that next. Muscle power deficits, radiating pain, related pain, and then some psychosocial types of patients that we have to be aware of because they are at risk of becoming chronic pain patients. And when they become chronic pain patients, we define them as generalized pain. That's the ICF category. So let's go through each of these different categories and talk about the examination and treatment strategies, okay? So here's mobility deficit. So this is where I want you to engage with me, okay? So I'm going to come out of this PowerPoint. I'm going to ask you, think about the patients that you have seen or have learned about that have mobility deficits. So these are any body region, any type of pathology where you believe that their primary reason why they have functional limitations, challenges in life, is because they don't have enough range of motion. So I'm going to stop share for a second, or actually no, I'm going to open up my little screen here. I'm going to ask you to unmute yourself or even to chat in some answers. What are some common conditions that you have learned about or seen that are related to loss of mobility? Any thoughts? Rebecca, Patrick, Nikisha, what do you think?
About frozen shoulder.
Perfect. Frozen shoulder. I love it. What else? Looks like we've got some chats coming in. I'm going to look at that. So contractures, exactly. Impingement. So impingement could be related to mobility deficits. I'll share with you why impingement may have mobility deficits, but we tend to call it a different category. Hip or any body part? Yes, any body part. So that's Winnie. Perfect. Total hip, is that arthroplasty? So I would say yes, these guys, a lot of them have hip mobility problems. And before the total hip, they had hip arthritis. And the guidelines calls hip arthritis hip pain with mobility deficits, because that most of these patients will say, man, I don't have enough range of motion in my hip. It feels really stiff. So you are right on. So I'm going to put hip OA, knee OA. All right, someone has said, good morning. Contractures, hip or anybody. Yes. So Diksha. So what do you mean by yes? So any other conditions that you can think of where they're like stiff? Feel free to unmute your mic as well to speak in.
Neuropathy.
What type of neuropathy?
Lumbar.
Oh, okay. So like a lumbar nerve problem. Lumbar nerve problem will come in a different category because nerve problems are tied to radiating pain. But could there be stiffness related to nerve problems? For sure. So the beauty of this kind of theory is that these patterns can overlap as well. So yeah, so lumbalgia. So people can have low back pain. Think about grandma and grandpa who says, my back is so stiff after I get up from sitting, right? So I would say spinal arthritis, regardless of where they have the arthritis, whether it's at their neck, whether it's at their thoracic spine or their lumbar spine. Sprained ankle, okay? Sprained ankles, I'm going to ask you, Chris, are sprained ankles initially very stiff or are they initially very loose? What do you think? Right. So sprained ankles typically fit the other category that we'll talk about in a second, where the joint moves too much. But eventually, after we immobilize them, they end up becoming ankle pain with mobility deficits. So people transition through these categories as well. Okay? Good. So someone said Yanda. Well, Yanda is not so much tied to hypomobility. Yanda's theories is people tend to move in ways that are dysfunctional. And eventually that could be because of different muscle firing patterns, different muscle tightnesses and weaknesses. That is probably tied more to movement coordination impairments. Disc herniation, okay? Possible, except disc herniation is likely more related to nerve problems. Okay, rheumatoid arthritis. It can depend. Sometimes rheumatoid arthritis, the joints are stiff, they're swollen, or they eventually become eroded, right? Joint damage, and eventually the joints become hypermobile.
About carpal tunnel, that would be considered a mobile deficit?
No, not necessarily.
Not
So
more nerve.
it's under nerve, exactly. So that's what I want you to start thinking about, right? Is soon we're going to come to a category that's going to talk a lot about nerve problems. Okay, so very good, you guys, well done. Okay, so I'm going to move on because you're going to see how some of these categories you've talked about fit the other categories, and that's the value of having this conversation. So I'm going to throw a few other common ones here. Think about someone who just finished their total knee replacement. Remember how stiff that joint is? So post-TKA could be like that. Someone who has fractured their elbow, post-immobilization elbow stiffness, right? Someone who just came out of their cast after Colles fracture. So post-immobilization elbow stiffness or wrist stiffness after brace, after cast, right? All of these guys fit that category. My life sucks because I don't have enough motion. And I start to hurt when I start using my wrist and hand or my elbow in the ranges that I don't have available that I need for function. So here's the important thing. When you talk about the key findings, okay, so I'm going to jump in here and just say that when we teach the PTs what to examine, so they've heard this story. Man, my knee is so stiff. It hurts when I walk on it. I'm 50 years old. It sounds like this person has some degenerative joint disease. I'm thinking first, not ACL tear. I'm thinking, oh, that sounds like a stiffness problem, degenerative joint disease. And because I think that he's complaining of difficulty squatting, difficulty getting up and down from a chair, he doesn't have enough range of motion, I suspect. So our examination strategy from the PT perspective is range of motion, active range of motion, passive range of motion, and accessory mobility. Does that kind of make sense? And the muscles that cross the joint, because I think some of you had put muscles or even talking about yanda in some way. Muscles and tissues, like contractures that you wrote, muscles and tissues that cross the joint, that could limit that mobility. Because once I have assessed, you could not squat because you did not have enough hip flexion. I measure. Yes.
Michael, can I interrupt real quick?
Go for it.
We have a participant in the waiting room who's trying to get back in. Are you able to, because it's not, I don't see them on my list.
Yep, let me check.
Are you able to let them in?
They're in.
Thank you so much.
Perfect. Okay. So now let's talk about interventions. The therapist has said to you, this person has hip osteoarthritis. That's on the prescription. They've labeled the evaluation hip pain with mobility deficits. This patient says, I'm having problems walking, getting up and down from a chair, I can't squat, and the therapist has measured active range, limited, passive range, limited, accessory motion, limited. So, I'm going to have you guys chat in real quick. What kind of things, and we're going to go into the app. Here is the patient complaining of sharp groin pain. Because that's right by the hip joint. So it could be an adductor strain. It could be a SI joint, pubic symphysis problem. It could be a hip joint problem, right? The hip joint's right in there. So if I click on the link, you can see that here are your common hypotheses. Hip OA, adductor strain, labral tear, sacroiliac joint. I always want you to think about, as a clinician, man, I wonder if this patient has any red flags that might be present. Is this a younger person with leg cab Perthes? Right? Could they have some type of ovarian cyst problem? Or are they younger and having slip capital femoral epiphysis? So all of these little red flags are here for you to kind of consider. Man, I think the PT might have missed something. This doesn't sound like the typical OA patient to me. Okay, so I want you to see that the red flags are there. So, the therapist, here's your patient. The patient often reports gradually worsening deep thigh or groin pain.
There may be a history of trauma or dislocation in the past. Pain may be reproduced with transitional movements after prolonged sitting or standing. The patient has difficulty with weight bearing and squatting, revealing limited end range mobility of hip flexion, adduction, and internal rotation. The pain typically gets progressively worse with weight bearing activities like walking.
So I'm going to open this back up to the group. What did you see about this patient that makes you think that he is a mobility deficit? This is just the movement analysis, right? This is your patient walking in after the eval, and you are basically asking him, hey, show me what kind of things you do that are limited and painful so I can figure out why did the therapist choose to make me do these interventions. So let's see what you guys have written. And I'm admitting more people as they come back in. Any thoughts?
So we're supposed to look at the video of that guy. I mean, you showed us the video at first of that guy walking.
Yep.
We're supposed to, I guess, describe from how he's walking what's wrong.
Yeah, describe and look at what he's complained about, what functional movements he can or can't do.
Okay.
And help. Yeah, go for it.
It kind of looks like he has a little bit of problems with his hip flexion. It seems like it's a little bit tight because his trunk's leaning a little forward when he's walking.
Right.
Kind of shifting his weight over to the other side, kind of guarding it maybe.
Fantastic. So some of you have said he couldn't bend down all the way. So when a patient says, I can't squat, I can't bend, I'm always curious, well, do you have enough range of motion to do that? So the therapist has to go in based on what the patient says I can and can't do and what I've shown you about how I move. And they decide to do the key examination related to mobility deficits, which is why you guys will end up doing the reassessments of hip range of motion. Here's your active and passive range of motion assessments, accessory mobility assessments. You're trying to decide the thing you told me you couldn't do, which was squatting. Do you even have enough range of motion to do that? That's my job. That's what I can restore. But I have to figure out whether you have impairments there or not. That is the way the therapist is thinking. So when the therapist finishes his eval and says, this is limited, this range is limited, this joint is stiff, please provide interventions that will help to unstiffen this joint. Your job is not to necessarily jump right in and start strengthening this person's glutes. Do you see what I'm saying? The primary impairment of a patient with mobility deficits is first range of motion. Eventually, after you restore the range, you start restoring the strength. But if you spend your time doing 5 or 10 different things that do not address the primary impairment, the patient cannot get better. It takes time to unstiffen the joint. So if you spend half of the treatment session doing strengthening, when what you should have done and spent the full treatment session doing range of motion restoration, you will have reduced your treatment benefit by half because you spent time on the less important impairments. So how I want you to see this patient is this is the common exam for mobility deficits. Imagine when we play through the app, when you start talking about the different body regions, you will see that the examination for frozen shoulder is almost exactly the same. It's active range, passive range, accessory mobility, and the muscles that cross the joint. And the treatment strategy, okay? So what I wanted to talk about here is what is the intervention strategy? What have you guys seen that we use or has been prescribed to treat people who are stiff? So you tell me. Anybody?
Joint mobility.
Yeah,
joint
love it.
Mobilizations.
Joint mobs. What else? Static stretching. Range of motion exercises. So think about what you just said, okay? Modalities. What type of modalities? Give me some examples. Heat, paraffin on the elbow, contrast bath. Right. Okay, so what you have just done is become a guideline-based, sniper razor-focused therapist assistant who can do the right thing for the patient instead of pull out the shotgun, fire at everything that moves, and hope that one of the things you did is useful. Does that make sense? Yeah, pull out the shoddy, right? Exactly. When in doubt, you pull out the shoddy. But I'll tell you, the clinical specialist, when things are like crazy and we don't know what's going on, we pull out the sniper rifle and we go after one thing at a time. Because by going after one thing at a time, you can eliminate what is not the right thing to do and then figure out what is the right thing to do. If you always fire with the shotgun, what you're left with is not much. Okay? It is chaos. Your whole life will be chaos. You can't test things. There's no science to that. So, I'm going to take us back to the app because I want you to see how powerful your reasoning is. Hip osteoarthritis, we are going into the interventions. There is always a little video that I think you should watch. This video gives you an overview of the theory behind how we manage from a specific to the hip problem, mobility deficits. Okay, so I want you to watch that. But what I want you to see here is, hey, the patient had limited hip flexion. Then I have a cluster of treatments that you have learned from your professors on how to improve hip flexion, on how to stretch the posterior capsule, on how to distract the hip joint. Okay? You may not end up doing the full manipulation. You could just pull on it. Give it some traction. But notice how, for the bulk of the manual therapy interventions, they are built around improving mobility. And when you think about the therapeutic exercises, first, I want you to think, I must restore mobility first before I go to strengthening. Because things get injured and inflamed when you try to strengthen things when they don't have enough range. Okay, this is very common in the knee. Think about your post-op knee patients and you're beginning to do strengthening and their knees beginning to swell up again. That is because you have not taken care of business. The business is, when patients have range limitations, I must restore that first. Be focused. Be a sniper. Don't fire shotguns all the time. They kill things. Things that you didn't want to kill, they're all dead. Okay, don't go there. All right, so think about it. The examination strategy matches the intervention strategy. And eventually, as the patient responds because their range of motion is getting better, then I move them to the next phase, which is you have normal range, I'm going to start strengthening. And here are all your common strengthening exercises. The whole point of this conversation for you and I today is that you now know that mobility deficits are tied to an examination strategy of, and I'm going to take us back to the PowerPoint so you can see what I'm saying. The examination strategy of mobility is mobility assessment. Nothing special about that. Life does not have to be so complicated. If it's stiff, check if they have range, yes or no. And if it's stiff, do things that unstiffen it. That is how you take care of all of these people. So I'm going to take a second and ask any questions. Typically, so the question from Jarek is, how much range of motion is adequate to begin strengthening? Remember that your goal is to restore normal range. Now, at some point, think about how many elbows that have been fractured that will never get more than 110 degrees of elbow flexion. They're stuck. So at some point, you have determined that 2 weeks later, I have been sweating and pulling and mobbing that joint. It is not going to move. At that point, you start strengthening. But you've done your darn best to give them normal range. So ultimately, I think, exactly, 2 weeks, nothing happened, it's time to snipe. It's time to get busy. But you're moving on, right? You're like, I've taken care of range. I need to start taking care of strength. All right? So, and I would say it's not 2 weeks. It is the therapist or the therapist assistant has to make some clinical reasoning. This guy has 6 weeks with me. I have been working on his range of motion for 2 weeks. It has gone from 90 degrees to 110 degrees, and now the last week I've made no changes. So you have to decide, is that as much as we're going to get? Is that enough elbow flexion to bring a burger to his mouth? Because he wants to eat an In-N-Out burger. If that is enough for him, then you're moving on. If that is not enough for his function, then I need to keep going. I need to keep pushing on it. Or you bring him back to the doctor and say, hey, I have been working on this range for 3 weeks. I'm not getting the range that he needs to be able to function in life. What are we going to do? You refer back to the therapist. You refer back to the doctor. All right? All right, moving on. Let's talk about the next category. This is the category, is it detrimental to begin strengthening within pain-free ranges while continuing to make more gains in range? Very good question, Saki. So if you can do some basic strengthening, like quad sets, some muscle activation, there's nothing wrong with that. You'll notice that in a lot of the post-op protocols, that little bits of muscle activation, you begin early, right? That's important. But you want to be careful to stay out of the end ranges, because that's going to start stressing the joint, and the joint then becomes inflamed. So yes, it's okay to begin strengthening. You just have to try the right type of strengthening. All right, movement coordination impairments, guys. This example, so an example of this is MCL or LCL sprains. So let me explain what this language means. In the guidelines, movement coordination impairments, the reason why it occurs is, think about the MCL sprain. Someone is sliding in to get the soccer ball from you and hits your knee from the outside, right? So I'm going to illustrate that. Don't mind all of my tabs. I've got a lot going on in life. Okay, so MCL sprain. Let's take a look at the image here. Here is the story of the MCL sprain, okay? The joint has moved so far out of neutral that it is now stressing structures that help it to restrict motion. The cause of movement coordination impairments, back pain, knee pain, elbow pain with movement coordination impairments, is the patient, whether it is through trauma or through repetitive movements, okay, has now begun to stress a structure enough for it to become symptomatic, pathologic. Okay, so when he lands, if he is in valgus and he does that over and over again, eventually he will get a sore knee. Or if another player comes to steal the ball, whacks his knee inwards, a one-time trauma, can you see how the joint did not stay close to neutral? So by going into a adduction position, a valgus stress, right? So, sorry, I clicked on that, didn't need to do that. So here, the whole point I'm trying to make is movement coordination impairments. The tissues get injured because of a choice of movement, moving in ways that stress structures, or some type of traumatic movement that stressed the structure too much. Okay? So that's how I sprain and strain ligaments, or I strain muscles, because I choose to move in ways that stress the structure too much. So I'm going to take you back to the slides here and ask you, what are some other common sprains and strains where the joint has moved so far out of neutral that it has now stressed some structures? Go for it.
Inversion ankle sprain.
Perfect. In fact, any ankle sprain. What else? ACL tear. That's the whole story, right? The knee, the tibia went too far anterior. Boom, ACL is injured, partially torn, or completely ruptured. What else? Labral tear probably is related to too much movement. The guideline calls it something slightly different, but you're pretty close to right on, Chris. Okay, whiplash, yes, perfect. UCL, right? How does someone get a whiplash? Their joint moves so far out of neutral, right? Whiplash. All right, that's not what I was expecting. Whiplash injury. The joint moves so far out of neutral that structures are stretched, compressed, nerves are compressed. Whiplash is a messy problem, but it fits under movement coordination impairments because the excessive movement is what drove the injury. Is that fair? So, I love it. Your comments are good. Rotator cuff tear. There is a lot of connection to movement coordination impairments because there's a lot of lax shoulders. But I would say that rotator cuff tear is going to fall under muscle power deficits. It's a tendon problem. Okay, so low back strains. Perfect, low back strains. And Fuchs injuries, okay? You guys have got the idea. Let me confirm what you just said. Look at a Fuchs injury. The joint has moved so far out of neutral that structures are being compressed, stretched, strained. All of that is happening. You don't strain yourself when you fall on a neutral wrist. You'll probably fracture something, but you won't sprain it. Well, depending on how hard you fall, you'd sprain anything. But look at this joint position. Okay? What was the other one that you guys just said? You said low back strain. Okay, I want to make a very important point because this will help make everything make sense when we talk about lumbar stave. Okay, so look at low back lifting injury. Look at this guy here. Do you see how his spine is so far out of neutral that when he loads that sucker up, it is going to stress ligaments, discs, muscles have to pull this long lever arm up. Notice how the opposite, when he lifts with his hips and knees, his spine is close to neutral. That means he is not a movement coordination impairment problem. His spine is not being stressed here. This guy's spine is being totally stressed. That's why sprains and strains, you don't know what's going on in there. Everything is being sprained and strained. Okay? So that brings us to the next category. What are the key findings? I will tell you that as a PT, what I'm looking for is how do you move? Do you choose strategies that are too far out of neutral? Because that is going to start stressing structures. And or for the person who says, Yanda, I'm curious, are there structures that are tight or limited in other places that are forcing you to move too much in your low back or forcing you to move too much in your shoulder or your elbow or your knee? So I'm looking for hypomobility in surrounding regions and hypermobility in the area of injury. Which is why some of you have taught, so you tell me, MCL or LCL sprain, what is the common special test? What is the common special test that you have learned for your MCL? Valgus stress test, right? I use the same type of stress test for all my movement coordination impairments. If it's a shoulder problem and I think they're moving too much, I do labral tear tests like the crank test, like the biceps load 2 test. If I'm looking at the ulnar collateral ligament that someone talked about, the sprain and strain of the thrower's elbow, I am looking for valgus stress test of the elbow to confirm that there's hypermobility there, they're moving too much. And then the therapist is thinking, where are you not moving enough? Why is all this stress happening at your elbow? So I'm going to assess the shoulder joint, the thoracic spine, the hip joint, all of these areas that they should be moving at. I wonder if you're not moving there. So hypomobility of surrounding regions, hypermobility of the injured region. Okay, I'm going to move quickly into treatment. So I'm going to give you a good example. When you had the patient who has an MCL sprain, or for yourself, when you sprained your knee or your ankle, what did you do for your intervention? What do you think? You iced it because first you must manage pain and inflammation. Right on. So after you manage pain and inflammation, what else? What do you see these guys wearing? What do you see these guys wearing? Compression sleeves for swelling, good. And braces. What position do you usually put the joint in when you put the brace on? Let's say for the knee. Exactly. Neutral bracing, because when the joint is in neutral, the structures are least stressed. That is how I protect that tissue from being injured further. That is how I reduce stress to the joint and whatever tissue has been injured. I keep it near neutral. And I allow it to stiffen back up a little bit because it moves too much. That's why you do all of this ACL, Lockman's test, valgus stress test, moving valgus stress test for the elbow. All of these tests are to tell you this person needs stability. I'm going to take you one step further. The patient says, I hurt my back lifting a box. Now it hurts to bend. I cannot bend forward. It kills my back. What position do we usually train the patient to be in to heal from their back sprain? Neutral or prone, because those tissues, the muscles, are quiet when you're in prone. They don't need to hold you up. So the muscle sprain feels better. The muscle strain. The joint, the ligament sprains, right? All of those feel better because you put them near neutral. That is why you do lumbar stave training, because patients need you to help them find a position where the tissues are at rest so that they can begin their healing process without fear, without pain limiting their every movement. That's why in all your low back problems, training the TRA, exactly. No, I would say that you can tell them to sleep in any position that is comfortable where their spine is neutral. It is more neutral spine than it is any one particular position. Okay, so that's towards Alvin. So the point I'm trying to make here with this type of patient theory, think about the person who's hypermobile or who sprained or strained some tissue. Our management strategy is, first, if it's acute, reduce pain and inflammation. Then it is to brace them near neutral. Whether you use their muscle brace or use an external brace, you will see that all of a sudden their pain begins to get better. And then I have to make sure that the muscles and tissues above and below have enough flexibility so that I can move in multiple different places, right? Because when people can move in multiple different places, they don't have to move in one place. And that is why you end up having lots of stress and strain to structures, because you can only move in one place. All right, so the overall picture that I want you to take from movement coordination impairments is your job is, first, reduce pain and swelling, immobilize, and then as the symptoms are beginning to get better, they eventually convert into a mobility deficit. They've been immobilized for 3 weeks, for 6 weeks. So now I need to restore their mobility. So I mob them and stretch them. And then I have to make sure that they're strong enough. So then they transition. That's why we sent out that image. Let me pull up that image for a second here. How come I can't find it? Hang on. Here is the image of the rehab pyramid. Let's see. Okay, I will find it in a second. I think you guys have it. The reason why we gave you an image of that rehab pyramid is because at the base of that pyramid, hang on one second. At the base of that pyramid is pain and inflammation. So here is my rehab pyramid. And that was one of the things I wanted to talk with you about anyway, okay? Because as you are going out into the clinic, you have to make a decision. What is the right thing for me to be treating and spending most of my time on? You always think first, is pain and inflammation taken care of yet? If not, then I need to manage that. Because if you try to joint mob or strengthen or do balance training, you are out of order. The body can't do it when there's inflammation there, when there is pain. And when I'm done treating pain and inflammation, I need to put them in good postures that don't continue to provoke the tissue. And then I need to figure out, do they have enough range of motion and muscle tissue length and joint mobility to do the movements that they need to do in life? So the priority system is reduce pain and inflammation, put them in good postures, restore range before you restore strength, before you restore balance and functional movement, because functional movement needs these foundational pieces to be taken care of first. What do you think of that, guys? Does that make sense? So when I come back to here, basically I'm thinking, okay, you have just moved too much. I need to reduce your swelling and inflammation, so I'm going to work on pain and inflammation control. And that could be from ice, modalities, any of the things you need to manage inflammation. I always just remember, how do I manage an ankle sprain? I reduce the pain and reduce the movement of the joint, keep them away from end ranges, and I brace them for a bit. Eventually the pain gets better. So then I need to restore the mobility and strengthen the muscles around the joint and eventually move them up into function, cutting, jumping, landing. But I can't do any of that until I've worked my way up the pyramid. Okay, so that's the big picture. All right. Do you want to, I have a couple more categories to go through, but actually what we can do is, let me think. Should we take a quick break? Do you think everybody needs a quick break, or let's run through it? Okay. Alvin, what about Catherine? You tell me when you want to take quick breaks. Any thoughts?
I will keep an eye on the chat. Let's get through muscle power deficits.
Okay.
I think that'd be a perfect time to take a break.
Perfect. All right. So someone mentioned earlier, just every hour would be nice. That's perfect. Okay. So I want you to think about muscle power deficits are typically related to tendon problems. And that can be any type of tendon problem. So patellar tendonitis is one of them. Please type into your chat or unmute yourself and help me fill out this list. What kind of tendon problems have you learned about? Perfect. So lat epi, I love it. Achilles. Yep, lat and medial epi. Shin splints, yeah, actually shin splints is right. Golfer's elbow, yep, that's medial epi. We've got patellar tendonitis. Oh, someone mentioned earlier, remember your rotator cuff tendon, your impingement? That is a rotator cuff tendon problem. So I would call that rotator cuff impingement. Biceps tendon, perfect. Okay, I love it.
Your hand and wrist.
Hand and wrist, right? De Quervain's. Right, De Quervain's. Right on, guys. Okay, perfect. Now, what is common about all of these problems? What is usually the mechanism of injury? What do you think? Well, pain is a sign and symptom. Think about overuse, overload, falling, or, yeah, exactly. Either something got strained hard, right? It got torn while you were... Here's a common example. Patient's walking down the stairs, misses a step, reaches out to grab the stair, overuses the muscle and partially tears the muscle tendon problem. Here is a person who jumps all the time, patellar tendonitis, tendinosis, or Achilles tendinosis, sudden load, okay? So muscles don't get hurt unless you overuse them or you use them too much in one moment, right? So now I will ask you, what do you think we do from an examination perspective? Because you're going to be doing the re-examination. How do you tell if a tendon is involved? What do you do for the re-exam? What would you do if someone said, yes, my Achilles is very painful? How do you prove that that is really the Achilles problem? And how do you recheck that when they're coming in for the re-eval? It's essentially resistance, MMT, right? So your MMT, your stretching of that tendon, so a stretch and palpation. So that already answers my key examination findings. I stretch it, I palpate it, and I resist it. That is how we determine, is a tendon involved? But I'm going to make this one more step more complicated because I want you to understand that a lot of these patients, we have an initial treatment strategy, and then we have a global treatment strategy. So in the initial treatment strategy, I'm going to go here, interventions. For those of you who have had a tendonitis or have seen someone being treated, what was the treatment strategy? What did you do?
Isometrics. Start off with isometrics.
Okay. I love that you're going there. That is usually not where we start. Okay. You could, depending on the irritability of the patient. So I'm not sure. Of course, it's different for every patient. Isometrics, eccentrics, submax, all of that is part of the treatment strategy. It depends on how irritable they are, right? If they are hot, red, inflamed, they cannot move it, there's no way you can even do isometrics. But what you're saying is critical. Okay, perfect. Hot cold therapy, rice, let it rest. Alvin loves rice, right? So put it this way. When something is overused, then I have to get people to stop using it. So immobilization and rest. Classic example of how to treat the inflamed acute overuse syndrome. Okay? And the next part is I have to unload that tissue. So the mobilization and rest is unloading. Okay? And I need to educate them. What should you do and what should you not do? Okay, there is an article from my friend, Todd Davenport at, he's in Stockton at UOP, right, at Pacific. He wrote a paper about the management strategy, which is EDU rep. That is educate. U is unload, which is what you just said. R is reload, RE is reload. And then P is prevention of reoccurrence. So how does this all play out? First, I tell you what not to do. Then I tape you, I brace you, I stop you from doing whatever you're doing so that tissue can calm down. Then, when those tissues are no longer inflamed, I need to start reloading the tendon. Why? Because the acute tendinopathy or the tendinopathy usually has some type of collagenous dysfunction. The collagen is no longer aligned in the appropriate directions. The only way we know how to fix that problem, I mean, think about the tendon often in chronic tendinopathies are thickened. That's why you palpate it, because it tells you a little bit about how chronic that problem is. But I need to reload it, and the only way we know how to reload it is with resistance. So you can start with isometrics, but the difference is you want to reload with some duration. It's not just, right? It's not just an on and off type of, it's not just an on and off type of muscle activation. It is hold it, and then slowly release the muscle. So you're doing concentrics and eccentrics with a long duration, because that is what helps the collagen to reorganize itself. You cannot do that when you are in the painful inflamed stage. It will make him worse. You're adding to the overuse problem. So eventually, I will start doing isometrics, concentrics, and eccentrics, but there's a load time. 1, 2, 3. So imagine you're doing a heel raise. You go up 1, 2, 3, and then you go down 1, 2, 3. That's concentric plantar flexion and eccentric plantar flexion over a span of 3 seconds up, 3 seconds down, because the time duration of the loading is what helps the reorganization of the tissue. This general idea of how I help people with tendinopathies applies across the board. Rest, slowly reload, and reload with tension. Time under tension. And remember that most of the loading, the resistance that you do, should have a 4 to 5 out of 10 level pain. You need to push it hard enough to actually create some pain to get the remodeling. I apply that same theory. You're going to see that same pattern played out in the app. Okay, so I've got 5 minutes. I want to play through a couple of patterns with you in the app. We just looked at mobility deficits, hip osteoarthritis, right? So here is, in the app, you can either go and play with your colleagues, hypothesis generation. What kind of patient shows this type of pain pattern? Okay? But you can also go straight to the hypotheses here. So it depends on how you want to go through the app. So let's talk about an adductor strain. The adductor strain has a patient who's complaining of groin pain and difficulty with walking because the adductors fire. They prevent your legs from swinging out, abducting. They fire during swing. Okay, so they're complaining of groin pain. What do I do for the exam? I palpate it, I resist it, and then eventually here, when I'm doing my range of motion, I will be stretching it, right? Because when I do abduction range of motion, I'm stretching it. So the theory, same theory applies. So I still have to assess. I'm the movement specialist. I'm going to assess your range and your strength, right? But when we get to the management, so let's look at, one other thing I was going to say. There are associated impairments. There are reasons why people sprain and strain the hip musculature. One of the common impairments is glute strength. So it is not a key finding. It is not necessarily the direct cause. It may be an associated cause. I will have to manage this eventually. After I finish taking care of the adductors, I will have to restore this. But I don't start restoring this when the adductors need my attention. So no shotgunning, more sniping, right? You have determined that the adductors needs your tender love and affection. You need to take care of that puppy. So I'm going to go in and look at the treatment strategy. Here is my manual therapy. I'm going to relax it, turn it off, calm it down, and I'm going to do some gentle soft tissue as appropriate. Eventually, I need to reload it. So here will be some of my training of functional movement, and I need to do some strengthening. Now let me see if I have another category here. So I think I need to add in one more category, which is isometrics and concentrics and eccentrics for your adductors. Because remember, we said in EDU rep, I need to reload that tendon somehow. So you have to wait for that pain to become better before you start strengthening the adductors. Okay, so that theory needs to hold true for you. And then, of course, throughout the app, you have patient education. These are the things that you should read because it will help you describe to the patient, here's what's going on, here's how long it will take, this is what we're going to do in therapy, and this is what you can do to help yourself. Okay? And if modalities are indicated, here is some common taping techniques you can use to help with unloading, right? EDU rep. So that is your sprain and strain, your movement coordination impairment. Well, that's actually this is considered muscle power deficit, right? Sprain of the adductors, strain of the adductors, muscle power deficit. Okay? Here is the label. You see, the reason why we're talking about that label is because when you can label it as a muscle power deficit, right? Adductor strain is also a muscle power deficit. Hamstring strain is a muscle power deficit. Examination is the same. Palpate, resist, stretch. Let's look at the interventions. Therapeutic exercise. Eventually, we need to stretch it, but not initially, right? You don't want to stretch things that are acutely injured. And essentially, I will need to start strengthening the hip muscles, reducing the hamstring dominance, and then strengthening the hamstrings. Let's see some functional movement retraining. Okay, so we're going to teach them to walk with shorter stride, teach them to reduce hyperextension of their knee that might be stressing their hamstrings. So overall, what I want you to think about is your muscle power deficits need to be rested. Then slowly the tissue needs to be restored in its mobility, so soft tissue mob and gentle stretching. And then eventually you need to reload the hamstring muscles. Okay, so what you'll see here, probably after our meeting today, I'm going to add in a category here that is reloading. And there will be some hamstring strengthening there. Okay? We are now at 11 o'clock. Let's take, how long do you want to give for a break?
We usually do about 10 minutes, so probably coming back at about 11:10.
Okay, let us meet back at 11:10. We will finish up talking about radiating pain, related pain, and we'll look at some of the hip conditions, and then we'll be done for today. With me, at least. I'm not sure what the other plan is. So, does that sound good? We'll meet back at 11:11. All right, so you know what I'm going to do when we are done with today, I will email you, actually I'll email what we filled out today. So all of these things were the things that we typed out. I will email this to you so that you actually have it kind of all filled out, right? Because I think this is very important in terms of setting your mind up. If you see the big picture, you can deal with the small picture. If you never know what the big picture is, you're constantly just doing whatever you think you're supposed to be doing, but you have no idea why, right? So this is why we're spending this much time resetting the foundation so that as you're going through each condition week by week for the next few weeks, you have some of this foundational concepts already floating in your mind. All right, so you guys, I'm confirming you guys can see my screen, right? I'm pulling up the chat.
Yes.
All right,
Yep.
Very good. All right. Now, let's talk about radiating pain. So some of you have talked about disc herniations, you've talked about carpal tunnel syndrome. In the guidelines, when we talk about nerve problems, we often talk about radiating pain. Okay, so back pain with radiating pain can be spinal stenosis. Back pain with radiating pain can be disc herniation, right? Because when the disc herniates, it herniates onto the nerve root. So now you have sciatica, you have pain shooting down your leg. So what are some common other pathologies that are nerve related? And I will start us off with, someone mentioned carpal tunnel syndrome. What else?
Radiculopathy.
Right. Cervical or lumbar radiculopathy. Very good. Any nerve problems at the elbow? Right? Cubital tunnel syndrome. Any nerve problems at the ankle and foot that you can think of? Where's my little chat? So funny bone, okay. Cubital tunnel, good. Ulnar nerve, Guillain-Barré, tarsal tunnel syndrome, right. Okay, so the point I'm trying to make here is that when the patient's signs and symptoms are typically coming from a nerve problem, we have a strategy on how we examine it, and we have a strategy on how we fix it, okay? So, the key findings from a PT's perspective: what movements stress / strain the nerve, what movements compress the nerve. So I'm going to ask someone with nerve pain of the low back, okay, spinal stenosis, let's say. I'm going to ask him to show me, can you bend forward for me? Can you bend backward for me? I'm going to watch which directions provoke your nerve problem. Is it when I strain the nerve, like bending forward? Or is it when you bend backwards, where I compress the nerve because I'm closing down the foramina? I need to know, because part of the treatment strategy is avoid positions of compression or strain. I need to help you find positions that will reduce irritation to the nerve. That's the only way the nerve can calm down. So we're the movement specialist. We determine what movements and postures are continuing to stress structures that are either compressing or bulging on or closing down on the nerves, okay? So that includes postural exam related to nerve stress. The other thing that we tend to do is we do an assessment of entrapment sites. The nerve is usually entrapped by something, whether it's compressed on or bulged onto, whatever the case. So there's always an entrapment site assessment. So we're looking at muscle tone, we're looking at scar tissue, we are looking at bony entrapment. That is why when you finally get your PT order, you're part of the plan, right? How are we going to help this patient? There's usually something related to avoid these movements, avoid these postures, because I need to avoid positions of compression or strain, and reduce entrapment. That entrapment reduction can be soft tissue mobilization, so that ties to the interventions, right? The interventions is usually avoid positions, postures, or movements that strain / stretch or compress the nerve. How's the nerve going to get better if all the time you're sitting, you're stretching it? You're stretching something that's irritated and inflamed. Or how is a nerve going to get better if the way that you stand is always so extended, hyperextended, that the foramina where the nerve comes out is always compressing the nerve? The nerve cannot improve its blood flow. It's always inflamed. So we have to find positions and postures that avoid stress, strain, and compression. Then I need to do entrapment reduction. Okay? Eventually, when I reduce entrapment, I've soft tissued the tissues around the nerve, or sometimes it's not soft tissue, sometimes it's bony structure. Think about cervical radiculopathy. The part of the way that I improve or reduce entrapment is I'll do side bends or side glides to open up the foramina, reduce compression on the nerve. Okay, so this might be soft tissue reduction or joint framina, joint or bony framinal, what do you call it, decompression, so to speak. And then usually we add some type of nerve mobility. So improve nerve sensitivity and mobility. What kind of things have you seen that we use to improve nerve sensitivity and nerve mobility? Things that you guys have learned in your class. What do you got? Nerve glides, neural sliders, tensioners, flossing, right? Perfect. You don't usually do that until you have done entrapment reduction. You've helped the nerve to begin to calm down. And usually we use sliders before we use tensioners, because sliders do not necessarily stress the nerve. Tensioners will stress the nerve, right? So we usually start with sliders first. You get the most movement of the nerve, and you basically continue to nourish the nerve back to health. The movement helps the nerve break through the entrapment and also improves the nerve's circulation. Okay? So let's play through the app together. We are back in the orthopedic app. So I've chosen the orthopedic app. I'm going to go to hip and thigh. I'm going to choose a pain pattern. So this person is having pain, buttock and lancinating leg pain. Please type in for me some hypotheses, conditions that you might think might be causing this. Okay, so show me what you got. Sciatica. Sciatica from what? And there could be a number of different causes, right? Sciatica is just nerve pain down the leg. It could be caused from a lot of different things. So sitting on a wallet, right? Compression on the nerve, lumbar nerve compression. That could be stenosis. Lumbar disc herniation, right? That could be the inflammation from the disc herniating onto the nerve root. Piriformis syndrome. Perfect. So let's go back into the app. Well done, guys. Here is my hypothesis. Piriformis syndrome, hamstring strain. Your alternative hypotheses, if we go in here, hamstring strain because of the pain pattern, right? So the pain pattern indicates that these are some possible hypotheses. So you can look at the prevalence. Okay, 5 to 36% of people with low back pain have this problem. We can watch.
The patient often presents with symptoms in the buttocks that may radiate into the thigh and leg. Aggravating positions or postures include sitting on hard surfaces or objects like their wallet that can increase compression on sensitive nervous tissue. Cross-legged sitting can also place the piriformis on stretch, which in turn may add compression to the nerve. Patient often reports symptom reproduction when staying in prolonged postures that put tension in the nerves, like slump sitting or bending forward from standing. Activities like walking or running that may activate hip musculature may irritate already sensitive nervous tissue.
Okay, so here's my exam. This is what the therapist is doing. I have a bunch of piriformis things that I'm going to prove whether the entrapment is in the piriformis, right? I'm going to palpate the piriformis. Here, palpate the entrapment site. Look for hypertonicity. Look for scar tissue. I'm going to make sure that the hip has normal mobility, but because this is a nerve problem, I'm expected to do a neurologic exam. So here, you as part of the rehab team, when patients have radiating pain, it is indicated for us to do a neuro screen because you need to keep track to see if this nerve problem is getting worse quickly. If it is getting worse quickly, this is a time for you to refer back to the primary PT. You know what? Last week when the person walked in, they didn't have any weakness. This week, the patient has foot slap. something isn't right. This is not a piriformis syndrome. So you refer back to the PT. The PT comes back in and does a more detailed assessment and determines that the patient actually might be having a significant progressing neurologic problem, and refers the patient back out to the physician. Sure enough, there's a disc herniation going on, and they had to do some type of decompression and fusion. Okay, so your job as part of the team is to know that when people have radiating pain, I am doing a neuro screen because I'm helping to keep track of someone's mom, someone's dad. I'm making sure that I'm not just sitting there ultrasounding their piriformis when they have a full-blown disc herniation that might end up causing severe problems later. Okay, so there's your lower quarter neurologic exam, and the therapist, because they suspect a nerve is partly irritated, we do a straight leg raise to kind of get a sense of how sensitive the neural system is. Because I will measure this straight leg raise and go, okay, PT, PTA team, we need to improve this straight leg raise to make it match the other side. But in order to do that, I need to calm the nerve down. So how am I going to calm the nerve down? Well, I'm going to put them in positions. So let's go into the intervention. What can I do? Well, I need to reduce entrapment. I'm going to calm the muscle down. That will reduce the compression on the nerve. I'm going to do some contract relax to gently stretch out the overly tight piriformis. I'm going to do some soft tissue. Just be careful, right? Because that's part of my entrapment reduction. And then I'm going to improve nerve mobility. Sliders first, and eventually tensioners. Okay? And then, when I finally finish managing the nerve problem, there's no more nerve pain. They have now transitioned from hip pain with radiating leg pain, or buttock pain with radiating leg pain, to muscle power or movement coordination. They don't move properly. Their muscles are weak. So then I will transition my interventions to therapeutic exercises of movement coordination. I'm going to strengthen the glutes. All the things you learned in TheraX. I'm going to train them on how to move so that their adduction internal rotation, right? They're moving with too much adduction internal rotation. I've got to train them to not do that. Here's a number of different ways that you can do that, because I think that may be compressing or stretching the piriformis. That's the picture overall of how we examine radiating pain and how we treat radiating pain applied to the piriformis syndrome. Okay, applied to the hip. So far we've talked about hip muscle power deficit, right? We've talked about adductor strains and flexor strains. We've talked about movement coordination impairments, well, kind of, meaning in the hip joint, the times that you get, sometimes, let's say labral tears, right? Labral tears in the guidelines are not directly defined as movement coordination impairments, even though lots of times it's because the joint is moving too much. The glutes might be weak, the hip flexors might be tight. So let's look at that real quick. Here's labral tear. Here is its exam. Commonly, we assess strength of the glutes. We assess the labrum. Here's the labral test that you did. And we assess range of motion of the hip. And usually what we do for these types of patients is we restore whatever's stiff. We avoid movements that are too lax, right? In some cases, the hip may be moving too much anteriorly, which is causing impingement. And we strengthen the glutes to control the anterior glide of the hip. So you'll see later in the examination or in the interventions, there's working on the excessively tight hip flexors, working on the adductors, the TFL, and there's a lot of strengthening related to glute strengthening because it helps to control the hip. Okay, so yes, labral tears has a lot of movement coordination But in the guidelines, it's generally defined as, if you look here, it's called non-arthritic hip pain. Okay, so it's not joint related. It's outside of the joint. It's the labrum. But the underlying mechanism is probably movement coordination impairments. They spend too much time in hip flexion and range that they are beginning to compress and stress stuff. So you have to educate them to avoid that. Okay. Last category, last main category, okay? This is related leg pain. This is directly tied to the low back. So when you guys get to the low back and you're playing through the app, you will have a category called radiating leg pain. We've talked about that. That's the nerve-related leg pain. But you also have a category called related leg pain. Related leg pain is almost another way to say disc-referred leg pain. So this person comes in, and I think the best way to define this category is we look for centralization and peripheralization. You have probably heard or learned a little bit about McKenzie method. These people are having leg pain, not necessarily because their nerve is involved. It's more so because the disc is damaged. The disc is referring pain into the leg. That is why when you do a centralization or peripheralization exam, which usually includes repeated movements of the spine, right? Repeated flexion, repeated extension, side glide correction. So the best way for me to illustrate what I'm talking about is to take you into the app. Low back. The person has pain going down his leg, but it's not narrow band like a nerve. It's more wide band. Okay, it's more referred. It's more difficult to localize. Okay, here is your lumbar disc disorder with lower extremity referred pain. This is basically a disc referred leg pain. The examination is typically some type of centralization procedure. We think that when we do repeated movements of extension or repeated movements of lateral shift correction, that we are doing something to the disc, and we are watching to see, does the leg pain change in location? Does it change in intensity? Depending on what direction I move them, that causes the pain to centralize, meaning to move back towards the spine, move out of the leg, right? Move up towards the spine. Depending on what direction of assessment, you might end up getting an order to do repeated lateral shifts in standing, because that helped to centralize the person's leg pain. Or repeated extensions in standing, because that helped to get rid of their leg pain. And if this weight bearing, right, the spine is weight bearing here, if this makes the patient worse during the exam, the therapist has probably moved them down to prone on pillows or prone lateral shift correction or prone on elbows, right? That's essentially, it's lateral shift correction but gravity eliminated. Or repeated extensions in standing but gravity eliminated. The whole goal of these repeated movements is probably to shape and change the location of the inflammation within the disc, which is causing the person to feel pain in their leg. They don't really have a leg problem. They just have pain that they feel in their leg. So you can see the management of this problem is typically, the exam is what movements centralize the pain, and the treatment is use those movements more to centralize the pain. Eventually, the leg pain is gone. So they are no longer lumbar disc disorder with lower extremity pain. They are now a guy who just doesn't know how to bend properly or twist properly. That's why he keeps blowing out his disc. Now, it's not necessarily a full-blown disc herniation, because otherwise he would have radiating pain. In this case, his straight leg raise is probably negative. His deep tendon reflexes are negative. Everything is fine. Okay? So this is a unique category where we use the McKenzie method to treat their leg pain. Because if this guy really was a nerve problem, extension wouldn't get rid of his nerve pain. You are compressing on the nerve root. That should make his leg pain worse. But because this is disc referred pain, repeated movements that correct his dysfunctional way he bends. That's why in the app, we always have under the exam movement faults. This guy probably chooses to move with excessive lumbar flexion. They do not bend at the hips and knees when they pick things up from the ground. When they sit in their chair, they're probably excessively slumped. When they move their hips, when they get in and out of bed, they probably do not move well in the hips and they move too much at the lumbar spine. A lot of this type of disc problems is tied to excessive lumbar flexion movements. That's why eventually you have to learn how to correct the way people function in life to reduce stress on structures. Okay? So, with that in mind, the last two categories that I think apply, okay, so the interventions here are essentially centralization procedures and movement retraining. And most of the movement retraining when it comes to low back is neutral spine, relatively neutral spine. So it's totally okay for you to bend your back here and there, but it's totally not okay to bend your back and try to lift up your 30-pound baby. It's totally not okay to sit slumped in a sofa for 3 hours to watch a movie, because in the end you're stressing structures, and eventually those structures hurt and can cause all kinds of issues. Right? So the movement retraining is, how do I keep tissues closer to neutral to minimize the risk of injury? That's what movement retraining is, okay? And that applies to all the joints. So in this last couple of categories, what I want you to see is there's pain with cognitive and affective tendencies. What we mean by this category is, now, this is primarily when it comes to low back pain, but we believe, and there's research to support, that depression, anxiety, and fear can affect many different types of musculoskeletal problems. So I think it's relevant to talk about it in its entirety. If you are meeting a patient, they finished their eval, they've come back and they said, man, my pain is way worse. I don't know what your therapist did, but they have screwed my back up. You are now part of the team that needs to help tease out, does this patient have depression, anxiety, fear? Are they on the fast track to chronic pain? These are conversations you need to refer back to your primary care, your primary PT, to chat about it. Hey, this is what I'm noticing about when you say certain things to this patient, they come back all flared up. Don't talk about discs bulging and herniating. Those kind of things are freaking this patient out. You are part of that team to help manage this type of patient. These patients that may have tons of crazy stuff going on in their lives. Think about our lives today. The stress of being at home, the stress of not being able to go out to interact with others. There's plenty of cognitive and affective tendencies. Every single patient you're going to see when they come back into the clinic sometime in summer or fall will have some form of cognitive and affective tendencies, some higher, some lower. The ones that are at risk, you need to communicate with your primary therapist. We need to have a strategy. These people are at risk for becoming generalized pain, where the pain is no longer coming from just a single tissue source with a very defined mechanism of injury. This person's brain is now so sensitive that just you showing him a picture of a disc herniating will cause him to have days of leg pain. That is a generalized pain person. He is centrally sensitized. He needs to be talked off the cliff, right? He needs to be talked off the edge. The way we manage these types of patients is usually positive reinforcement. Get them to move gently. Encourage them. Seek appropriate counseling. If needed, they should be on their anxiety and depression meds. There's a team of people that help to manage these different things. So the unique part of being a PT assistant, of being a PT, is we get to be their friends. We get to be in a relationship with them over the weeks, right? Unlike a doctor visit, one visit, no, you're not going to die. Here's 2 tests you need to take, and here are 3 medications. Come back and see me in a month. If you're better, you won't even see them. If they're not better, they're triaged to somebody else. We have the opportunity to develop relationships to recognize stressors, to recognize cognitive and affective tendencies, and begin to steer them a little, to get them support, social work, psychology, psychiatry. All of those become part of the way that we manage cognitive and affective tendencies. But you have to recognize that some of these patients come in with these things, and this cognitive and affective tendency can slow their progress. For no reason, they could have a big flare-up, 10 out of 10 pain, and all you did was mob their ankle. Makes no sense. But their brain can be that sensitive. Okay? So, with that in mind, I want to open it up for let me summarize real quick and then open it up for some questions. So I'm going to stop share for a second. Comments or thoughts? Any comments or thoughts? Questions?
Mr. Wong?
Yes.
I just have to say thank you. I mean, this was a first session together, and I'm just happy to be able to put everything together, the things that we learned at Gurnick, and being able to implement it into your learning and your teaching. So thank you.
Yeah, absolutely. Absolutely. Other comments, questions? Okay, so what I'm going to do for the next 10 minutes is kind of give you a call to action. This is your plan for the next 4 weeks, because your professors and I have put in a lot of time to help you think through and prepare you for the clinic. But the way you do that is you have to refamiliarize yourself with the common patients that walk in the door. Okay? Because there is a subset of patients, that are complicated. All of us scratch our heads. We're like, man, this one's going to be tough. But there is a large subset of patients that are relatively straightforward, and I don't want you to waste your life shotgunning, because your life will be increasingly confusing because you never figured out that this person had this pattern. This is how we generally manage that type of patient. And wow, when I follow the rule, when I follow the sniper approach, the patients get better, which makes me faster at helping these patients get better because I spend more time doing the right thing instead of wasting all the time doing 10 potentially right things, of which only one of them or two of them was the right thing. You wasted 80% of the time. Okay? So you have to be selective. You have to go, I recognize this pattern. I can see that based on the testing and the range of motion deficits and the strength problems, that actually this guy's primarily a mobility problem. Yes, he's weak, but I need to remember the pyramid, and I need to treat him based on the pyramid. I need to take care of business, take care of the key things first. My call to action to you, and Dr. Menti will have some worksheets for you to do, okay? Don't think of them as labor. Think of them as a guided tour of working your way through the app to refamiliarize yourself with the common conditions. Think about how powerful it is to walk into the clinic in fall or late summer where you're like, oh, I see you. I know your pattern. You're a mobility deficit of the knee. The reason why you're having all this knee pain is because you're 50 and over. You have stiffness of your joint. You have some weakness, but I know how to manage you from the pyramid. So I'm going to start taking care of business. I'm going to restore your range. Then I'm going to restore your strength. And then I'm going to teach you how to move. And patients start getting better. That's who you will become. And you do that by becoming familiar with the common patterns. Inside the app, each section, you will be marching through each section, playing through some of these patterns. Okay, so there's not enough time for me to play with all the patterns with you. We are, every week, every couple of days, we are going to play through a couple of these patterns. You're going to get to see a picture of the examination and see a picture of the intervention. And then the next day, you will have some case studies to discuss in your groups. So you can do some clinical reasoning. By the time you are done over these next few weeks, you will have refreshed all your tests, all the common treatments, the common modalities. Don't be afraid to explore. The whole reason why I walked you through the apps 3 times, at least 3 or 4 conditions of the main categories, is because I wanted you to not be afraid to go in there and get familiar with the patients who are going to walk in the door. This is your job. This is your chance to tie all the pieces back together, and I want you to do it together, okay? The reason why you do it together, meaning 2 or 3 of you together can work on these worksheets together, because there will be points where you're like, wait, I don't know why this is here. Someone else will have a different point of view and go, oh, that's probably here because this is tight, or this is weak, or this is the remember that test that we did, right? So when you group together to play through these different patterns, I mean, you could even just play the different pain patterns out. What's your hypothesis? Right? Buttock pain. Oh, buttock pain. That sounds like piriformis syndrome or a high hamstring strain. Or maybe hip osteoarthritis. By playing these through, you are actually sharpening your blade. You are preparing your mind and refamiliarizing yourself. And all of this, right? One of the marks of expert practice is that expert clinicians can do clinical pattern recognition. We can recognize the easy ones from the hard ones. The hard ones, everybody just rolls up their sleeves and works carefully and very deliberately to figure out the problem. The easy ones, that's the bread and butter. You don't want to have every single patient walk in and can't tell the easy ones from the hard ones. The easy ones are the easy ones. You make money for treating the easy ones. But really, they pay you to figure out the hard ones, to help the hard ones. Okay? So my vision for you is that every afternoon, and I think you'll get more details about this, you should go back and play the app through. You don't have to play every technique. Only play the techniques that you want to see, that you need to review. We purposely, every single one of these, I took screenshots of every technique because I wanted to help trigger in your mind something that helps you remember a technique you learned, right? This is, 10,000 years of my life, because I think the way you need to learn is to see everything tied together and to be able to have images trigger things that you know. And when you can begin to make sense of this story, of which you play such an important role in, when you can see what is the impairments that are driving this type of intervention, what is the overall strategy for why I'm doing reloading and eccentrics, those stories that we told today are the fundamental stories of rehab that will guide and help you understand all the interventions that you are doing. So this is not 4 weeks that are wasted. This is a magical moment for you to take stock of all the things you know, to see the bigger picture, and then allow your professors to help you develop some clinical reasoning. This may become the model of how PTA education will be. Looking at the big picture, reviewing a lot of the content that you know, and then doing cases to develop your clinical reasoning. It's a powerful moment. So I would encourage you to take this seriously, because every patient, somebody's mom or dad or grandmother, every patient is counting on you to not just be a technician, is counting on you to have some reasoning, to understand what problem they have and have a strategy, a meaningful strategy. I don't want you having a life where you're just doing what you're told and have no idea exactly why you're doing what you're doing. Right? That's a hard way to live. So that is my hope for you, my call to action for you, and I think you will have a little bit more of a discussion as you're closing out today with Dr. Amenti. Any comments or questions for me? By the way, guys, we are doing, just so you know, I'm so glad that you guys are had a good session. It's such a pleasure. I think tomorrow morning I'll be with you again just for an hour or so. I want you to know that every Friday we also have a webinar that we do for PT students and PTA students, and we talk through the app just like this, but in a little bit more detail because we only talk about one condition. If you go to, just let me show you where to go to find this, because I want you to become part of a group of people who are growing and learning together. So let me see, under student, here's free student webinar. So if you look at PhysioU.com under free student webinar, here are all the different conditions. So you will get to listen to Dr. Lemoyne, the guy in all the videos. He's a specialist at Kaiser, and you will get to hear him talk through the reasoning about management and exams. So I think it's very useful for you to go and listen in. So keep track of all of this stuff. We release a lot of stuff also on Instagram under PhysioU, so you follow us there. And I am excited to be with you tomorrow morning as well. So I'm going to hand it off to you, Dr. Amenti, and then any other comments that you want to make?
I just want to thank you again for coming to our class today and giving us a lovely overview of the of your program. I wish I had this when I started treating patients 17 years ago.
All of us do.
Because oftentimes in those early days, I did feel like I was walking in with a shotgun and just randomly aiming at a particular thing and just, okay, I'm gonna treat this. Let's see what happens. And learning a lot of lessons the hard way and seeing clinical patterns materialize over my practice,
Right.
So it's really, really, really cool to see those practice patterns, those patterns actually now are available for you to just learn about firsthand instead of just waiting it out and trying to sort it out through your practice. If you guys go in to your practice with this knowledge, I mean, my knowledge was, well, at the very least, I can look at strength and range of motion, and at the very least, I'll address that. And that's how I started. Is if I do nothing else, I'm going to make sure I've addressed strength and range of motion. Well, that's only part of the picture. And so then when you put everything else together by the coordinated movements, whether one muscle is overpowering another, those are the referral patterns. It's a huge deal to be able to have that knowledge going in, because then you guys can relax a little bit, not feel so overwhelmed. Like I've said before, I guarantee you, even after 17 years of practice, I've still had people still intimidate me and overwhelm me.
Right.
So it won't go away, but it's better. It's nicer to have that be like a 1% instead of
the 60%
of your
80%.
Practice.
Right. Exactly. Fantastic.
So super happy that we have this opportunity.
Wonderful. Well, I will leave you to finish off.